Good morning, everyone. Thank you for joining us and welcome to day 3 of this virtual Global Value Conference. So day 3 will be focused on partnerships and governance. And among other topics, it will look at how partnerships play an important role in helping both the public and the private sector work towards achieving the Sustainable Development Goals. My name is Charlotte Wagenaar. I work at the PharmAccess Group. PharmAccess is an international organization dedicated to connecting more people in Africa to better healthcare. So today I've been asked to share some experiences that PharmAccess has had over the years in building inclusive partnerships. These partnerships with both private and public stakeholders have been a key element in our approach from day one. So without partnerships, we would never have been able to have the impact that we've had so far. And with today's theme in mind, let's just start with this African proverb that I'm sure most of you are familiar with. If you want to go fast, go alone, but if you want to go far, go together. Partnerships are, of course, key, especially in the development arena. And of course, it's a pivotal time in the world in general, both in and outside the development arena, from shifting power structures in international politics to new strain on global agreements like the Paris Climate Accord. So development is currently moving away from the traditional donor and recipient approach and towards a more level playing field that builds equal partnerships. And rightly so. Many of the challenges we face today are so daunting, there's absolutely no way that any single person, company, or country can resolve them. So, before we get into the intricacies of PPPs and health statistics and jargon, which I will try to avoid, let me just quickly anchor this talk and take you back to why we do what we do. So, this is a picture of our founder, Joep Lange. In his work as a doctor in Amsterdam, he treated the first HIV/AIDS patients in the Netherlands in the early 1980s. This affected him deeply, and he decided to dedicate his academic career to fighting HIV/AIDS as well. Very successfully, the scientific research that he did helps lay the groundwork for triple combination drug therapy. And when the drugs became available in the West in the early 2000s, he refused to accept the fact that treatment was not available in Africa, where, in fact, people needed it most. Because that's his reasoning. If Coca-Cola and Heineken were able to deliver cold drinks to every corner of Africa, why should it be impossible to bring life-saving drugs? So he founded PharmAccess in 2001 to do just that, and he set up partnerships with many different multinationals. Heineken was actually the first company to join, making sure that their employees in 6 African countries had access to treatment. So these days, working with the private sector is fairly standard practice for NGOs, but Joep was heavily criticized at the time. And although he's no longer with us, his way of thinking continues to be a motivation to everyone that worked with him. So now you know where we came from and why we're called PharmAccess, so access to life-saving drugs. But since then, our focus has broadened considerably. So today, we also work on making healthcare finance and healthcare delivery more effective and ultimately more inclusive. And over the past few years, especially, digital technology has been starting to play a huge role in our approach. So, to get back to today's agenda, I will be sharing a few examples of partnerships that are generating real impact in the African healthcare sector. And broadly, they will cover these 4 topics. So, standards for benchmarking and quality improvement, building inclusive health insurance schemes, access to affordable debt capital for health SMEs, and finally, digital technology as an accelerator for improving access to care. But first, let's watch a short 2-minute film on the PharmAccess approach to give you a bit of a context. Here we go.
In most developing countries, the public sector is unable to meet the growing demand for healthcare of its people. Therefore, 50% of the people turn to the private sector instead, paying for healthcare out of pocket, since insurance is practically non-existent. Too often, this leads to catastrophic health expenses. Our aim is to increase access to affordable quality healthcare for low-income groups by strengthening the private healthcare sector. This is how we work. Let's look at 3 key stakeholders in a healthcare system: the doctor or private clinic, the patient, and the insurance company. The system needs the following elements to ensure further development: access to affordable capital, enabling the doctor and insurance company to improve quality care and serve more patients; prepaid subsidized insurance, enabling patients to access affordable healthcare without the worry of how to pay for it; and quality standards, enabling the clinic to offer the quality care that patients demand. Our organizations enable this process in order to reduce risk and increase trust for consumers, doctors, and the private health sector. This leads to an upward spiral of higher quality healthcare, more people being willing to prepay for health insurance, and steady revenues for providers. The impact of this process is constantly monitored. This sound situation attracts additional capital from the private sector, such as from banks and international investors, but also from the public sector, on the national and international level. With increased revenues leveraged by donor money, we can further develop local capacity and infrastructure for healthcare. Only then can healthcare start functioning for the poor. This public-private approach is currently being implemented in several African countries. It has set an example and has been a pathbreaker in development cooperation.
We're actually currently working on an update of this film, as it was made before digital technology started to become more and more central to our approach, but it still gives a pretty good idea of our problem analysis. So our problem analysis starts from the premise that the African health sector faces a huge disease burden and at the same time a lack of investments. So although Africa has just 15% of the world's population, it accounts for a quarter of the total global disease burden. And when you single out communicable diseases, this jumps to 47%. And despite this, less than 2% of global health expenditure is spent in Africa. So in our view, African health markets are stuck in a vicious cycle of low and unpredictable demand, low and uncertain quality of supply, and totally inadequate investments, both public and private. And we believe that health as a semi-public good should have large government intervention. However, many African countries suffer from limited state capabilities and poor institutions. And then at the same time, since insurance is virtually non-existent, many people pay for healthcare out of pocket, and this sends millions of people into even deeper poverty every year. So despite the fact that the private sector serves up to 50% of healthcare services, it's often weakly regulated and highly fragmented. And so far, anyway, it has also largely been ignored in development policy. So because trust in the system is low, investors perceive the risk as too high, and as a result, healthcare providers have limited or no access to capital. Hospitals are often overburdened or understaffed and ill-equipped, and they can't invest in improving their quality or expanding their services because they can't access loans. And low quality in the clinics means low trust among patients, which means they will be less willing to prepay for health through health insurance. After all, they don't trust they will get their money's worth. So reversing the vicious cycle into a virtuous one is key to achieving inclusive healthcare. And to do that, we need to work on both the demand and the supply side of the system. We need to build trust and reduce risk and improve quality and increase the total amount of money in the health system. And we need to build inclusive partnerships with strong local ownership to develop and implement models that are innovative, evidence-based, and scalable. So let's start with the first example, standards for benchmarking and quality improvement. For most healthcare providers in Sub-Saharan Africa, international accreditation is nowhere near attainable. They often lack qualified staff or functioning supply chains or even basic resources like power or water. And despite these challenges, they play an essential role in their communities. Often they're actually the only healthcare provider in the area. But in the absence of an objective rating system that's actually relevant for their context, they had no idea of or no way of knowing where they stand compared to other clinics or what they could focus on to improve the quality of their services. So for this reason, in 2011, the American Joint Commission International, JCI, and the South African COSASA joined forces with PharmAccess to create SafeCare. So the SafeCare standards are the first and only internationally accredited clinical standards that are tailor-made for small and medium-sized healthcare facilities in resource-restricted settings. And about 70% of the clinics we work with are actually private sector. So the SafeCare standards, they measure organization management, clinical quality, and safety, making it possible to benchmark and certify performance. They provide an international standard that's realistic for the healthcare landscape in Sub-Saharan Africa. leaving room for application of local solutions to specific challenges. So in short, the safeguard standards create a common language. And how it works is, it's not a pass or fail system. It measures and recognizes incremental improvement, and healthcare providers are supported to improve their quality by technical assistance from PharmAccess through local African partners. What happens is they first get a comprehensive safeguard assessment, which covers 13 areas of operations, from the actual medical care to management, as well as supporting activities like laundry service. So after the assessment, the clinic gets a detailed report with their score on all elements, and they also get a tailored quality improvement plan, which helps them decide where to start. And in the end, when they improve their services, they will attract more patients and generate more income. In addition, Safeguard creates data insights, making it easier for governments to evaluate quality and risks. So several African governments have adopted the Safeguard standards so far. In Tanzania, for example, the government has adopted the Safeguard standards and methodology as the national system for stepwise certification towards accreditation. And when you can benchmark providers, you can also start to work with pay-for-performance mechanisms, which will help improve quality even further in the long run. So this system has been working extremely well, and by the end of 2016, clinics using Safeguard were treating 2.2 million patients every month. And the Safeguard standards have become an important framework for transparency of information and benchmarking, and they've built trust in the market, and they're actually helping investors to make informed decisions and long-term financial projections. So the next example is about health insurance. So in the PharmAccess analysis, one of the symptoms of an underdeveloped market is high out-of-pocket expenditure. People are either unable or unwilling to prepay for health, suggesting a lack of trust in the healthcare system. And actually only a small minority of Africans have health insurance. So even though most people earn a living in the informal sector as a farmer or small market trader, public health insurance schemes ironically tend to only cover people in the formal sector. So this means many families are always one serious illness away from financial catastrophe. And data suggests that this happens to more than 150 million people every year, and that up to 100 million free fall into poverty due to out-of-pocket health expenditures. So when trust in local institutions is low, people have more faith in their own communities and local leaders. But when you look at how our social and health insurance started in Europe, it was a voluntary process, not led by the state. Funnily enough, when it comes to developing such systems in Africa, many people feel it should be led by the state. So in our view, social infrastructure always starts private and then grows public. 10 years ago, we started piloting and implementing innovative prepayment mechanisms and risk pooling structures to improve access to care for low-income groups. Let me highlight one of our public-private health insurance schemes, the Kwara State Health Insurance Program in Nigeria. We've been working in rural Kwara State since 2007. Kwara is one of the poorest states in Nigeria, and over 90% of the population is poor. Most people earn a living as farmers, so their income is not just low, but also unpredictable, and access to care was very limited. So for this reason, the Kwara State government and the private Nigerian insurance company Hygeia enlisted the support of PharmAccess to provide quality healthcare services in the state. In 2007, this PPP formed the Kwara State Health Insurance Program, with the support of the Dutch Ministry of Foreign Affairs. So when the program started, health insurance was still a fairly unfamiliar concept to the population of Kwara, and the first few years were spent sensitizing people on the concept of insurance. The program pooled funding from external and local sources, including state and federal governments and communities, so that it could lower the barrier for people to enroll by partly subsidizing the insurance premium. So individual enrollees pay 12% of the premium themselves, and the rest is subsidized. The Kwara State government now covers 60% of the insurance premium subsidies, but it's currently in a transition phase and on its way to taking over funding of the program completely. So in addition to stimulating the demand side, the PPP focused on improving the supply side as well. Because if the quality of care on offer is not up to par, if the clinic is too far away, if there are no doctors, or if the pharmacy does not have the right medicines in stock, why would people prepay for such substandard services? So Over 40 contracted health facilities in the state, both public and private, were renovated and upgraded. And the effect on communities has been considerable, as both those insured and also those not participating in the program benefited from the improved services. And the upgraded facilities have actually received more than 1 million patient visits since the start of the program. So in Kwara, the solvency of the insurance fund served as collateral, lowering the investment risk and making investments in the healthcare supply chain feasible. And private equity fund IFA also invested in Hygieia, followed by FMO, IFC, and Satya Capital. And this investment was even expanded in 2016. So in order to ensure that the impact would be measurable, rigorous scientific and operational research has been an integral part of the approach from the start. The Amsterdam Institute for Global Health and Development and the Amsterdam Institute for International Development worked closely together with the Lagos University Teaching Hospital and the University of Ilorin in Nigeria on these studies. And the impact evaluations that they've done together have also helped train a critical mass of massive young Nigerian researchers. So they found that average out-of-pocket spending went down by 52%, meaning people now have a financial safety net should they fall ill. 70% of pregnant women were insured, and there's been a 200% increase in healthcare utilization under those insured and a 90% increase overall. Data analysis done by the World Bank office in Nigeria also suggests that Kwara has become the second best performing state in Nigeria with respect to maternal and child care. So now the international recognitions, the concrete on-the-ground results, developments in the Nigerian political landscape, as well as in the international development arena, have brought the program into a new transitional phase. Now, with the support of the World Bank Group's Health in Africa initiative, the partners are also working towards a statewide health insurance scheme to build a financially sustainable future. And the Kwara State House of Assembly is set to pass the Kwara State Health Insurance Bill, making health insurance mandatory. And in the end, mandatory insurance will ensure cross-subsidization of the poor by the middle class, and thereby helping to reduce some financial burden on the state. So in conclusion, in PPPs like the Kwara State Health Insurance Program, public donor money can be leveraged to reduce investment risks and mobilize private capital, while the alliance at the same time helps to build trust. So that brings us to the next example, access to affordable debt capital for health SMEs. As I mentioned before, the private healthcare sector in Africa actually delivers over 50% of healthcare services, often to the poor. And as such, it has a crucial role in complementing the public system. Many people continue to view the private healthcare sector with some level of discomfort because they feel that healthcare is a public good. But it's important to note that private does not necessarily mean for profit. Many clinics are actually run by religious groups or other charitable organizations. And healthcare is often approached from a medical and ethical point of view, logically. However, the long-term viability of any healthcare system will also depend on economic fundamentals. So the growing burden of healthcare costs in developing countries is an issue high on the political agenda. More and more, governments are also exploring what role the private sector can play in ensuring the most efficient use of the resources for healthcare. So in short, if you want to achieve sustainable socioeconomic development, developing the private health sector is a precondition. And we think that any policy that overlooks the private sector will inevitably fall short in effectively contributing to improvement or change of the healthcare sector in developing countries. So to quickly zoom in, most health SMEs in Africa are owned by medical professionals with little to no experience in business management. So they're doctors and they're not business people. Their facilities often lack a credit history or adequate bookkeeping and accounting systems, or financial performance records or sufficient assets. And as a result, many are unable to secure bank loans and struggle to purchase modern equipment or even pay for basic repairs. So while Safecare was set up to address the lack of measurable standards, the Medical Credit Fund was established to bridge this financing gap. Ultimately, it aims to mobilize the financial sector, both locally and internationally, to invest in healthcare. And actually, since 2012, it has mobilized more than $40 million in capital from both public and private investors and donors. So how it works is Medical Credit Fund mitigates risks for African banks in order to bridge the gap for first-time borrowers in particular, by assuming a considerable share of the bank's financial exposure on these loans. So they cover the risk, basically. And over the years, banks have started to recognize the business potential of the healthcare sector. So their health SME portfolios that they have with Medical Credit Fund are among the best performing portfolios at these banks. And over the years, this has prompted them to introduce loan products of their own. And more they're assuming a larger portion of the risk. In 2016, this percentage actually had risen to 46%. Medical Credit Fund also develops innovative new loan products to meet the growing demand in the market. So in Ghana, for example, many healthcare providers struggle with liquidity issues due to late payouts of insurance claims. And Medical Credit Fund, to mitigate this, partnered with the National Health Insurance Agency to develop a receivable financing product that allows healthcare providers to discount the debts that the NHIS owes them to the bank. In another product in Kenya, Medical Credit Fund set up a partnership with the World Bank and Capital Tool Company to implement an invoice financing scheme for the pharmaceutical supply chain. At the same time, non-bank partnerships are also in development, for example in Tanzania, where we're building a partnership with EFTA, which provides loans for equipment with no collateral requirements except for the equipment itself. Another example is that Medical Credit Fund has a partnership with Philips, so that healthcare providers can apply for a loan to purchase Philips equipment at favorable interest rates. So what we're seeing is that historically 97% of all disbursed loans are repaid in full, and that's a result that's providing proof of principle that health SMEs are bankable even at the base of the pyramid. So in that sense, Medical Credit Fund and our partners, our 12 partner banks in Africa, are contributing to a healthier investment climate for health in Africa. Finally, let's take a look at this morning's last example, digital technology, and how it can be an accelerator for improving access to care. So digital technology has become a part of our daily lives, and not just in Europe. What we call the fourth industrial revolution is already changing societies and economies all over the world, and often actually much faster than in Europe. In Kenya, for example, the revolutionary mobile money payment system, M-Pesa, has changed the way people do business forever. It has opened avenues to finance for millions of people who did not have access to formal bank accounts before. Today, actually, even more than 40% of Kenyan GDP flows through this system. So this was an ideal foundation for a partnership between PharmAccess and M-Pesa pioneer Safaricom, which is Africa's largest telecoms company, and CarePay, a health payment platform. And together we set up M-Tiba. M-Tiba is an innovation that we believe is on the brink of revolutionizing the healthcare sector in Africa. So M-Tiba is a digital platform for inclusive healthcare that directly connects patients, providers, and payers like family members or health insurers or donor agencies, for example. And it enables people to save and send, receive, and pay money for medical treatment through a mobile health wallet on their phone. So the mobile health wallet is a unique closed loop with conditional funds that can only be spent on healthcare at selected facilities that accept M-Tiba. So already the M-Tiba digital platform is transforming how people in Kenya are paying for and accessing healthcare. In less than a year, nearly 1 million people have signed up. So on the demand side, M-Tiba improves access to healthcare by reaching people directly on their phones. And we do tailored offerings such as savings schemes, benefits, and health insurance at very low administrative costs. M-Tiba also benefits players on the supply side of the system. So healthcare providers, they serve more patients who are actually able to pay for the services and receive payment on the spot with no delays or fraud. M-Tiba also serves as an administration system. It generates data on medical treatments as well as financial transactions so that healthcare providers have all the information they need right at their fingertips. So this can help improve both the clinical and business side of their day-to-day work. So where they used to deal with leakages and fraud regularly, digital payments ensure that the money remains in sight and that it's transacted efficiently. And M-Tiba also provides many opportunities to improve cost effectiveness, for example, through mechanisms like joint procurement systems, access to finance for quality improvement, or capacity building through e-learning. Finally, on the investment side, the increased transparency and reduced risk and transaction costs means that Antiva is making it more attractive to invest in health. So the insight generated into clinics' business operations also lowers the threshold for clinics to qualify for bank loans. It also allows donors, governments, insurance companies, and even individuals to directly reach vulnerable groups or family members, for example, a family member living in a rural area. So the digital infrastructure provides near real-time data and allows for precise targeting of certain groups. For example, governments will be able to target pregnant women living in the slums. And as a result, payers can offer tailored products like digital insurance for the treatment of chronic diseases or vouchers to vaccinate children. And payers can also encourage people to save for health by offering top-ups if people deposit a certain amount into their Antiva account. So it's still early days, but we're very excited and we're working very hard to develop new products and services on this platform. And we have very high hopes for this. Actually, this last week, Antiva won an FTIFC Transformational Business Award. So that's something we're very proud of. And it's actually all up to our partners who we couldn't have done it without them. So we're looking forward to next steps. Finally, just to give you an idea of how important partnerships are to us at PharmAccess, take a look at this crazy slide, which is by no means complete as there's not enough room to display all of them. So the main thing I want to stress this morning is that we never could have achieved what we've achieved without this very broad range of public and private partners, donors, and investors. And together, we have indeed gone far, and we hope to go even further and achieve even more impact for people in Africa. So that brings us to the end of this presentation. Thank you so much for listening and for making it all the way to the end. If you're interested to learn more about PharmAccess, please feel free to start a conversation with us on Twitter, LinkedIn, or Facebook. But first, enjoy the rest of the conference. Thank you.